Hi friends, I am working on getting the Instagram feed set up and our internet is having serious issues. So hopefully this will happen. My husband, as some of you know, is a web developer. And if someone is here, please tell me if you can hear me. So my husband, who is a web developer, our internet's, if you're on Instagram, my internet is not working well. So my husband, who's a web developer, told me to reset the router or the modem or something. And I'm like, I don't know which one that is. And he's like, it's the square one. So I looked up in the cabinet and there's like, I don't know, 6 square black pieces of electronic equipment. And I'm like, I don't know which one it is. So I unplugged all of them and plugged them back in. So who knows if this is going to maintain for us. Hopefully it will continue to work. And if not, then too bad. Hello, Madeline Barnett. Thank you for joining us on YouTube. I am trying to learn the platform over there and excited that there's some people hanging out over there. And hopefully this will go having some connectivity. All right, lots of people joining over on the Instagram. Good deal. I always try to pin a topic and it just never works. So can someone just comment and on Instagram and say like live Q&A and I'll just pin your comment if it will work. All right, so let's start with a couple of questions. You guys have been giving me the best questions today. I'm so excited. So a lot of times when I do these, I ask for questions. Hi, Sarah May. Hi, Abigail Simpson. Thank you for joining on YouTube. I'm so happy there's people on the YouTube platform. I really am trying to do the YouTube thing and learn the YouTube thing, and I can't do that without you guys helping me. So thank you, and thank you for everybody who's been supporting me with the videos recently. Anyway, so I don't remember a time when I have planned a live chat. Shining on my face. Such excellent questions that weren't like repeats of the same things that we always get. LNT, you rock at YouTube. Thank you. That is very nice. I'm trying so hard. It's so hard. So yeah, I've been super pumped about that. And let's go ahead and start. So I'm going to just find a question to jump into. Oh, my mom says hello on YouTube. Hi, Mom, on YouTube. Thank you. All right, so on Instagram, Brittany Carey says, do you work with WHNPs, which is women's health nurse practitioners, in your office and in the hospital, or are there just CNMs? So in my hospital, I don't have in my clinic who is wonderful. We also have a PA in our clinic who is absolutely wonderful. I love both of them very much. And they both see clinic patients, OB and GYN. They both, I think, mainly focus out of desire to focus on GYN things. And then in residency, I thought my shirt was on backwards. In residency, I worked with a women's health nurse practitioner who kind of ran our triage unit in conjunction with the intern on labor and delivery. So I have worked with women's health nurse practitioners and I have worked with NPs and PAs. We used to have a nurse midwife in our clinic and we don't currently. I would love to have more nurse midwives. I think that that's somewhere where American medicine can really improve as compared to like European models where we have a lot more nurse midwives who are helping us manage low risk and normal prenatal patients and also to improve postpartum care for patients. So this flash of light is driving me nuts. I'm gonna have to turn it a little bit. Yeah, I would love to work with more nurse midwives. I think that's the future of how we battle the shortage of OBGYNs and the burnout in OBGYN is by incorporating more of them into practice with us. And I think it's more common in certain areas. I did a really fun live chat on Instagram a while back about the difference between different types of training for midwives. So it's really important that you said CNM, which is certified nurse midwife, rather than just midwife, because there's a difference. I'm going to adjust this light up here, and then if anybody on the YouTube platform has a question, I'm going to prioritize questions over there. I'll answer all the ones from the Q&A sticker that I can get to as well, and any from the IG chat as much as I can. First, I'm going to make me very shiny, and also it's very hot in here, so I'm going to turn down the air. So give me like 2 seconds, maybe 6 seconds, maybe a little longer. Okay. No, it's still really shiny, but I think it's a little better. So it is like super hot in here. As some of you may or may not know, well, a lot of you know if you follow me, this office is actually a storage room, and it is just extraordinarily hot in here. Calendar. Oh, these are great questions. Okay. No, I don't have a favorite clothing brand. I am very basic when it comes to clothing. I'm very bad about shopping for myself, and I'm very bad about investing in like really good clothing. Like, I don't know, this is not something I've been good at traditionally. So, I mean, I love figs. I wear scrubs all the time. And if I'm going to shop at the mall, like Express is probably where I'm going to go, but I'm trying to get out of my Target and H&M phase because I feel like I'm too old to buy crappy clothing like that. So I would love to find more like US based brands that are, I don't know, renewable resources and things like that, animal friendly brands, things like that. So if you have recommendations, please feel free to leave those. Where'd you go? This calendar is from Target, but it's Emily Lay, who some of you know I am internet friends with on Instagram. She did the twin giveaway with me not too long ago. She makes the simplified calendars. She's so wonderful, and I love her. So buy her things at Target. She didn't tell me to say that. I just bought that when I was at Target, but also I really like her. So, Emily Baller, how do you emotionally handle dealing with pregnancy loss and stillbirth on a regular basis? Okay, this is a very good question, and it's actually one that I get relatively commonly, but one that I try to answer each time, and I need to just do a full video on it. So stillbirth and pregnancy loss are complicated subjects, and it's not easy to just tell you how you handle it. Because if I just say, oh, I do this or that, it sounds like it doesn't affect me. And that's not true. Every late birth that I've ever taken care of, I can vividly see in my brain when I close my eyes. These are patients who resonate with you forever. And you have kind of a, like a mental box that you keep these patients, and they mean a lot to you. They're special to you. You think about them, you pray for them, you wonder how they're doing on a not rare basis. And then the flip side of that is that I found love and resonancy of taking care of these patients because I saw a gap. I saw a gap in what I read online from women who had been through this and what I saw clinically about how we took care of them. We had an excellent nurse at my last hospital who did very good grief care, and I learned a lot from her. If you're watching this, thank you, Chris. And then I watched a really great job taking care of women who were going through just unimaginable situations, and I learned a lot from watching people who did a really terrible job handling that. I learned a lot from reading blogs and Instagram posts and Twitter feeds of people who had been through this. And I just felt like I wanted to immerse myself in figuring out what I could do to make that less terrible for somebody. And so it became kind of an interest of mine. So I don't actually see this as something that you need to handle, or that it would be a lie if I said it wasn't emotionally difficult, because it is. But it's like, it's an honor, you know, to walk these women down that path and know that you don't understand personally what they're going through, but that you've talked to enough people and you've read enough personal accounts of women who have been through this to maybe at least have a tiny grasp on things so horrible, things you can not do to keep from making things worse, and ways that in the time going forward, you can show them that you care about them and respect them and that their baby's life mattered. So that's a very long answer, but something I'm really passionate about. So yeah, thank you for asking that, Emily Baller. Okay, hi, thank you for doing this. I love your videos. Is there a difference between prodromal labor and Braxton Hicks contractions? Thank you, Robin, on YouTube. Prodromal labor and Braxton Hicks are kind of the same thing. So Braxton Hicks is not really a medical definition. Like, we don't have that in our textbooks as a thing. So it is prodromal labor. It's just kind of like the lay term for it, I guess. And really the only difference between Braxton Hicks and real contractions is if your cervix changes. And so sometimes you'll have women who've been told, it is true that they're generally not as painful as real labor, but they can be uncomfortable. If your cervix is changing, then it might be real labor. If it's not, then it's probably Braxton Hicks. But yeah, that's a whole kind of continuum. It goes from just kind of random crampy discomfort to Braxton Hicks or prodromal labor to actual labor contractions. Mackenzie Foxall, if medicine were no longer an option, what would your dream career be, or what would you love doing the most? Oh, that is a really tough question. Do I still have my medicine knowledge? Because I really like doing this. I don't know if I could ever make a living doing it, but I really like this. And also maybe I'd just join the bucket list family. You think they would adopt me? Do you think they would adopt me and all of my husband? I'm going to go ahead and put that down as my, if I couldn't do medicine, I would be adopted by the bucket list family. All right. Let's see. I'm not trying to ignore you guys. There's a bunch of people on YouTube, thank you, and a bunch of people on Instagram, and a bunch of questions that came through in the live Q&A. So I'm going to answer another one from Instagram now. Annie Liz says, Pitocin without an epidural is Satan. This is more of a discussion than a question. Yeah, I mean, I'm not a big fan of pain. And if you've watched my birth story video, you're aware of that. I've also had an induction with a Foley bulb and Pitocin, and I also agree there that it's not exactly fun. I think Foley bulbs were created by Satan. Not really. They're very good forms of induction. We can talk about methods of induction at some point also, but yeah. It can be very uncomfortable. So I am constantly amazed by if you watch my birth story video, you're fully aware of that. And I would die. I mean, it was just, Darwinian theory would have me if I had to have a medication-free birth. That's all that would happen. Let's see. Have you ever delivered? Lauren Miso on YouTube says, oh my gosh. Technology challenged. Okay. Lauren on YouTube, have you ever delivered a baby with someone with mastocytosis, mast cell activation syndrome? Most doctors aren't familiar with it, but anaphylaxis can occur due to anesthesia or many other things. I'm not familiar with that. Would it happen like right at delivery? Because I don't always know if there's something going on with the baby, if it happens like weeks or months later, unless mom tells me when she comes back to see me again. So not sure. So I stopped washing it all the time, and now people tell me it's pretty all the time. So there you go. Just stop washing your hair. Lots of dry shampoo in there. Heather Ann, I had a natural labor. It was a wild experience. I deliver people all the time who don't get epidurals or pain medicines, and they do awesome, but I would not. It's personal preference. Let's see. What are your thoughts on this new HPV cure discovered by that Mexican scientist? I know nothing. I don't know what you're talking about. If someone has literature on this, please send it to me, but my thoughts on it right now are that it's probably not real. If you're breastfeeding or pumping your youngest since going back to work, how's it going? Good. I have a video that I'm planning to film in the very near future about 5 tips for pumping at work. And pumping is going fine. I feel like it takes a lot of planning. I am comfortable with it at this point because I've done it so many times. And this time has seemed a little bit easier because my schedule is not so erratic like it was in residency. So it's going fine. I'm trying to bank enough milk now that I can go out of town for a couple of days at the end of March, and crossing my fingers that I can make that happen. But for now, I would not have enough milk to leave for days at a time. Oh, my face is really red. It's unusual. It's really hot, but that's what's wrong. Okay, sorry. All right. Hello, Jesse Peters. Hi, Jasmine. Lauren says hi again. To get an IUD removed, if the strings have retracted, I was given misoprostol and all of the muscles started contracting and I have horrible tremors. Have you seen this before? I can't answer personal medical questions on here. So if you're having problems like that, then definitely talk to your doctor. I don't usually, I don't use a lot of misoprostol, so not like for things like that. So, Tina Blair Dixon, I'm going to you because I think this is very important. I had an unmedicated VBAC because of a precipitous delivery. I was embarrassed by how much I yelled and swore from the pain. That is nothing to be embarrassed about. People all the time do this. They say, I'm sorry, I'm so sorry that I yelled, I'm sorry that I said word, I'm so sorry this, that. Like, please do not apologize. We are not judging you unless we're judging you as being superhuman for pushing a baby out of your vagina with no pain medicine. You don't have to apologize. It's not embarrassing. We see it all the time, and it's very normal. I would scream and yell and use curse words if I didn't have pain medication during the delivery too. Now, some people do really excellent. That's awesome. Good for you. I'm always incredibly amazed. I had someone just recently who did that, and I was just incredibly amazed. But it's also okay if you get down to the line and it requires some yelling and screaming. It's perfectly fine. Jesse Peters, any update on New Zealand plans? No update. I got to work right now focusing on getting board certified, and then that's going to take time more and more because we very nearly went right when I got out of residency. But yeah, that's on hold. Not really on hold, but I've got to focus on one thing at a time, which I'm terrible at, if you haven't noticed. I like to do at least 15 things at a time, and get my board certification first. Marissa Spencer and then the mental health mama both want me to answer this question. So I'm going to go with this real quick, and then I'm going to go back to the queue. Thoughts on the increasing popularity of detailed birth plans? Do you ever see this becoming a hindrance rather than helpful? Does it create a lot of unmet expectations or disappointment? I can go both ways on this. I think it really depends. I find, and this is hopefully not going to come off as me like patting myself on the back, but I find that my patients do not come in often with detailed birth plans. And I don't know if it's not common or because we spend a lot of time talking about what they want and I try to answer their questions throughout the pregnancy, and maybe they don't feel like that's completely necessary. I don't know. I haven't had a lot of those. I have had a few. And I do absolutely see why we would be worried that this can set people up for unmet expectations. I think it's okay to have a birth plan. Here's what I tell my patients. If you would like to make a birth plan, that is great. Please bring it in to one of your appointments several weeks before you deliver so that we can go through it together. I'd like to go through it and let you know where we're going to run into roadblocks so that we can prepare for that together so that you don't end up just completely blindsided by it. So for instance, if somebody says, I don't want, I'm trying to think of a good example. A lot of people want, so I would say like, delayed cord clamping, check. We've got that. No matter who delivers you in this practice, that will happen unless there's a medical reason that it can't. Sometimes people will say, I don't want Pitocin after delivery, and I'll talk to them about why I think it's important, but that they have the autonomy to make that decision. And then also tell them, you're going to run into some roadblocks here because starting Pitocin after delivery of the placenta or before delivery of the placenta is in the nurse's workflow. And that's their routine that they do every day. So imagine you do something the same way every day. You might need to be reminded that you're going to do it different. And starting to do it or doing it is not because you're trying to spite the person. It's because that's your typical way that you do things. And so does that make sense? Like I'll try to identify places where, hey, if this is really important to you, you need to make sure you're telling your nurses, because when you're in the heat of the moment, delivering a baby and anything to make sure that they don't miss things. And so sometimes when you have requests that are outside of that, it's not that you have to ask them several times because they just don't want to do what you're asking. It's because that's just what they're typically doing. So I guess all of that to say, like, communication feels so much more important to me than very detailed birth plans, but I do occasionally have a patient who has a very detailed birth plan, and I think that's fine. We just need to go through it ahead of time. Like, don't just show up in labor at 39 weeks with a 4-page birth plan that you haven't mentioned to me. That's very difficult to accommodate. But other than that, we can usually ward off unmet expectations by setting the scene for here, if this, then that, if this, then that, and just establishing trust is super important. So I don't know. We can handle it either way, but I do like to go through them beforehand. Let's see. There are really good questions in this. I'm going to answer this one just because I like it. What's your favorite candy? I just like candy. It's so bad. I'm a bad influence on my kids for this, but I almost always have candy in my office. I don't always remember to replace it, but I try to. I think it goes in phases. Sometimes I really like Swedish fish. Oh, do you guys know Buc-ee's? Have you been to a Buc-ee's? Please, if you know Buc-ee's, say yes or something in the chat. They have these cinnamon bears that are incredible, like made in heaven. I love those, and I love licorice. Like, not like Twizzlers, plain old Twizzlers, not much. Like the real red licorice, not black licorice. Yeah. Oh, so clearly the answer is I like candy. I saw a good question here. I'm looking for, oh, here. Can you do a video on endometriosis? I can work on a video on endometriosis, but I also did a podcast with Jade Roper about a year ago now. Her podcast with Carly Waddell is Babes and Babies, I think. So if you look back in their podcasting section from March of 2018. There's an endometriosis podcast that's really, really good. Someone else asking if I see a lot of patients with endometriosis, and yeah, I mean, that's definitely well within our repertoire of things that we see. Have you tried your Willow pump yet? I have several times. Definitely some pros and cons. I'm still working through the logistics of it, and there will be a good review video and some pictures and comments on it on Instagram at some point. And yeah, I don't want to give it all away here, but I've only used it for a couple days, so I don't want to comment too much on it just yet. I need you to watch the video because I'm very desperate for, I don't know. I am fall and I didn't sleep, and I slept at the hospital last night, and you're going to have to excuse me if I say anything crazy. Everything I say is a little bit crazy. Let's not get sidetracked here. How is Pax? Pax is good. He's actually very easy to get to sleep tonight, and so he's learning how to hold up his head. He'll have his 3-month milestone video out soon, even though he's been 3 months for almost a month, and he's great. He's getting big and fat and chunky and adorable. I had a particular question I'm looking for that I can't find now. We'll go back to that in a minute. All right, let me look through the chats. So over on YouTube, what do you look for in labor and delivery nurses? Oh, I think this was a question. Where is it? I really like the way Instagram has incorporated these Q&As into the live streams. Do you guys like it? Isn't it cool that you can see it? And I wish there was a way to stream. Oh, crap. I exited out of Instagram. Hopefully it didn't mess everything up. Okay. There we go. Qualities you love or dislike about nurses you work with every day. And that was a similar question. It may be the same person over on YouTube who says, what do you look for in labor and delivery nurses that work really well and are effective birth team members? Okay, so I'm going to go with swinging this from what do I love. So first off, you got to be my mom. If you are my mom, I would love you as my labor and delivery nurse. I mean, not that I'm biased, but she's actually an L&D nurse. All joking, I love a labor and delivery nurse who is like succinct and to the point. So if you call me at 2 a.m. and you want to tell me about a laboring patient, you start with age. So just like we ask the med students to present, age, G's and P's, meaning how many times they've been pregnant, what pregnancy number this is, and what their delivery outcomes have been. Age, G's and P's, gestational age should be the first 3 things that you tell me. So, hey, I've got this patient in triage. She's 26. She's a G3 P2002, meaning she's had 2 full-term deliveries and has 2 living children. And she's at 26 weeks and 4 days, and she came in for this. Like, that should be the way we start the conversation. And mainly because everything we do is so much more effective if it's got a routine to it. So if I'm sleeping and you wake me up in the middle of the night, I'm going to be much more effective at getting myself to understand what is happening and listen to it. I expect that follow. As opposed to if somebody calls and says, hey, I have this lady in triage and she came in because yesterday she started noticing that she was having a couple of contractions, but those kind of stopped yesterday, and you know, it's her 3rd baby, so she definitely knows what contractions feel like. Like, do you see how much harder it is if you're asleep in the middle of the night to get your head around what is happening? And so I really, really appreciate the nurses who are very good at that. I love it a lot. And then I love the nurses who just work really well as a team and like are excited for the delivery and want to do everything the best we can for the patient. This is like 99% of every nurse that I've ever worked with. They're just, the labor and delivery nurses are really unique. And I don't know, just the same thing that makes anyone a good member of the team is we all have a shared goal. People who can communicate well, I think, is what it comes down to. I want to be able to drives you crazy and safe. I want to be able to address that professionally and in a protected space, meaning like it shouldn't be brought up right in front of the patient. If I'm frustrated with you or you're frustrated with me, we should step out and talk about it. Like those are things I really respect is definitely people who can do that on a regular basis and move through it rather than letting things kind of build up and get frustrated. So I don't know. I've had so many L&D nurses that I loved working with. There we go. Let's see. Hannah on YouTube says, I was wondering if you have to bite your tongue when parents don't want to vaccinate their child, or if you just gently encourage them to do it with science and back of it. So I don't run into this a lot because I'm not pediatrics. Pediatrics is who runs into vaccinate their children. So I occasionally will have someone who doesn't want to vaccinate themselves against certain things, but I find that patients are very receptive to this if we talk about why I feel like it's important. And then people have the autonomy to make the decisions that they want. Now, childhood vaccines are a totally different story because there's a lot of other stuff that goes into that. And I obviously am a huge proponent of vaccinations, but I don't find myself on the side of talking to parents about that very often just because that's not really what my field does. On YouTube, Jasmine Sonia, thank you. Carter, do you prefer OB or GYN? That's a loaded question. I really love both, and that's why I do general practice OB and GYN. I love operating, but I also love nice, easy deliveries sometimes. So I think I like a good balance, and that's really why I decided to do this, because I like a little bit of all of it. Somebody had messaged me the other day asking like, hey, I really like GYN, but I don't really like OB. Can I just do GYN when I get in practice? And the answer is yes, but I don't think anybody should choose this field if they really hate half of it, because you're going to be miserable in residency if you don't like one of those, and you are going to rely on OB to build your practice when you're first starting out, because most people who are 40 or 50, unless they're new to town, are going to already have a GYN doctor who delivered their babies at some point in the past. So you rely on obstetrics to build a practice for the future. And then, I mean, I enjoy obstetrics too. So obviously there's some things that come along with obstetrics like that's okay. And I'm in a good practice for that. So OB nurse April, I don't currently work with CNMs, but I would love to. Lauren on YouTube says, do nursing students, medical students, PA students, midwife students ever bother you? I wouldn't say, I mean, yeah, bother, I guess. So having students is, I think, important, but I totally understand why sometimes you don't want to, because it's very hard to maintain your normal workflow and volume while you're also trying to teach. And the way that most practices are set up now really rely on you to maintain that workflow and volume. So it can be very difficult to teach in addition to seeing all the patients that you're supposed to be seeing and get people seen on time and effectively and keep everybody happy. So yeah, it can be challenging. All right, Instagram. Sometimes these cut off. So if you guys are asking questions like this one, okay, I'm newly pregnant, 4 or 5 weeks, okay to keep working out. So I can't answer questions like this. Like we can ask questions like, tell me about exercise in pregnancy, and we'll talk about that. But I can't answer patient-specific questions. Those questions should be always directed to your doctor who knows your history and your specific situation. I know nothing about you from this question, so I can't answer that. And I can't do medical consults on the internet. So this is like general learning and do really important things in life. Oh no, look, I turned you guys around and now I don't know how to fix it. Come back, Instagram. Ah, okay. So Anna on Instagram asked about what I like about my nurses that she can mimic in the future. We answered that maybe like 2 questions ago. This live chat will be on YouTube when we finish, so hop on over there after we save it and you can find the answer to that question. Someone asking about breast implants. I mean, not really my field. I know a little. Did you ever consider becoming a pediatrician? Yeah, actually, to be when I started medical school, I thought I wanted to be either a pediatrician or emergency medicine physician. And actually, after my first year in the summer, I did a like observership with pediatrics, and that was super fun. The pediatrician became my mentor and eventually my children's pediatrician after the twins were born. And it was really great. But I don't know. I found that I like to work with my hands. I wanted to be in people are either doers or thinkers, or you could be a combination of both, but I'm kind of a doer. I like to be doing things. Health, because I related to the patients. I enjoyed kind of being able to care for people over a lifetime, but at the same time be taking care of things that were fixed with instant gratification, like surgeries and stuff like that. And then in clinic, it wasn't just like in psych, you're doing all talking. It wasn't like that. Like it was a lot of, I don't know, procedures, pap smears, IUDs, LEEPs, colposcopies, hysteroscopies, clinic procedures, infertility surgery, emergency surgeries from the ER, obstetrics, things like that. Like there's lots of doing, there's a lot of thinking, there's a lot of adrenaline. Like it was a nice mix of everything. So I think that's what drew me to OB. But yeah, I did actually have pediatrics on my list starting out. Lauren, does your husband enjoy hearing your medical stories or does he cringe? He is not a fan of medical stories. Let me tell you, he's a web developer. And when I was starting medical school, we had just moved to town and we went for orientation. And it was like all the medical students and a few people had spouses or significant others with them. Well, we had just gotten married. I mean, we had literally gotten back from our honeymoon like 2 days before. And so I was like, why don't you just come to orientation with me? I can't remember. It feels like they invited spouses. There must have been like a luncheon that day or something. They were taking a tour of the school. It wasn't like formal orientation where you're getting like your badges and stuff. I wouldn't have taken them to that. It was something like a little more social than that. And they did a tour of the anatomy lab. And so we walked down in the anatomy lab and like there weren't any cadavers out, but they had all of the tanks in there. And we were walking in the door and he's like, oh, I cannot go in here. I don't want to go in there. I'm just going to wait outside. And the anatomy professor's like, you're not if you would like to be a medical student. And he's like, I, sir, am not a medical student. I would like to leave. So he left. So yeah, he's not a big fan. And during the great avocado injury of July 2018, he, I thought, was going to pass out before he got me to the urgent care to get my stitch in my finger. So yeah, not a fan of medical stories. Which is why it's nice to have my mom, because she can bounce ideas off of me. She gets it. Okay, let's see. Between peds and OB-GYN right now, thinking about NICU, but worrying about the sad days. I mean, there's going to be sad days in every field of medicine. There's going to be heartbreaking, terrible, sad days in every field. And you, like I was saying at the beginning of the video, you learn to find solace in that, making it less what these people are going through, reading about their stories or people like them and making it less terrible. You aren't going to have a field that has extreme happies unless you also are in a field that has extreme sads. And so you either choose something that's in between, like, I don't know, what's something that's in between? I'm blanking. Dermatology, maybe, like, but you still have cancer diagnoses and things like that in dermatology. So, but you're not going to be in a field like NICU or emergency medicine or surgery or OBGYN without having those polarized ends. And you just have to learn how to, I don't know, go back to the beginning of the video when I was talking about stillbirth. Like, that's, you just have to find your place in that so that you feel like you're doing good in terrible situation. You can go to YouTube and watch my video, OBGYN Dr. Mom 24, and that talks about kind of my journey into and through medicine when my babies were born and all of that. Elizabeth Chapman, do you have operating room sides at your hospital? I don't know what that means. Like which side of the patient I operate on. I usually stand on the right for all of my surgeries, which is atypical for laparoscopic surgery, but that's the side I like to stand on. So many questions. M. Tucker, do doctors ever feel personally slighted if the patient seeks out a second opinion? So first off, I probably wouldn't even know if the patient, I'm confident enough in how I manage problems and complications and things that patients have that I feel like you're probably going to get the same information. And if you don't, then there's probably two answers and you should have both of those options. I don't know. It's, I don't feel like that's personal, but maybe other people do, but I've never felt like that. Can you talk about Clomid and multiples? I've seen some doctors say if you're younger, your chances slightly increase. I don't know the for sure answer to that, but the risk of multiples with Clomid is like 4 to 7%. Are you NRP certified? I was in residency. I have not maintained that now. Yeah, I mean, it would. So Kendall Chef on Instagram says, do you have your NRP? I feel like our OB-GYNs would be really helpful for this. Our pediatricians or family practice can't be there as quickly. I don't know how I feel about this. So I am NRP certified. I maintained that through residency. I don't maintain it now because I work in a hospital who has in-house pediatrician all the time. But at the same time, I have a responsibility to take care of mom. Now, that doesn't mean if something was happening with the baby and there was no one else around that I wouldn't take care of the baby. Like, obviously, I would do that. But I can't take on the role of everybody, right? I have a big job with mom. She's just delivered a baby. She could have hemorrhages. She could have lacerations. She could be having blood pressure issues. There's all kinds of things that can be going on with mom. So while I do see the point, and again, that we should be the ones relied on to be the sole caretaker of a baby in a rural setting. So if the OB has time to get there, then the pediatrician and anyone else who needs to be there should also have time to get there. And I think it would be far more important for all the nurses who are around to also be NRP certified, because if one of the nurses is helping mom, someone else can step in and help the baby. And I think that's more typical. Again, if something was going on with baby, of course, if mom was fine, I would step over and help baby. Do not get me wrong. And I am capable of doing that. I've done that before. I have resuscitated babies. I've bagged babies. I've done all kinds of things like that. But my primary attention needs to be to mom. So that's kind of how I feel about that. I don't think anybody should be forced to do that. That's certainly not what we are trained for. Medical School HQ. Hello, Ryan. How are you? Nice of you to join us. What's your midnight snack when you're on call? Honestly, anything I can get a hold of, but I really like cereal and crackers. Just plain saltine crackers. That's what I ate last night when I was on call and stuck in the hospital, was plain saltines. We have snacks in our physician lounge, but I still chose the plain old crackers. Grace on IG says, what type of nurse is your mom? She's done tons of types of nursing over the years. Emergency medicine, NICU, home health. What else, Mom? If you're still here, probably not here. You should be in bed. You have to work early, but I can't remember what else. But anyway, labor and delivery is where her main passion lies. And she's been a labor and delivery nurse for more years than all others. YouTube, I'm going back to you. Sonia says, I've learned so much about ObGyn from your channel and Instagram. I don't think I would have developed an interest for if it wasn't for you. So thank you. Oh, I appreciate that. I'm really glad that you've been here and found it interesting. Hannah wants to know about being competitive for residency. The most important thing is just maintaining good scores and doing some rotations. A lot can be said for being genuinely interested when you're on your rotations and being willing to work hard and just be present. I don't know, get good letters of recommendation. But I mean, let's not lose sight of the fact that for better or worse, a lot of your residency application, getting the interview comes down to what your scores are. So. Lauren wants to know when I found my doctor voice or confidence. You're so well-spoken and knowledgeable. Thank you. I don't know. I have long been called aggressive and overbearing, and maybe I worked to transition some of that into what you're referring to, but thank you. I don't know when it happened. Maybe my mom can answer that if she's here or comes back. Or maybe, ooh, you know what we should do, guys? We should have a Q&A of things you want to ask my mom, either about her or about me. And then we'll do a YouTube video interview with her. Anybody? No? I don't know. You tell me if that would be good or not. Do multiple in your family, lots of one and triplet run, chances of it. Multiples don't run in my family. My twins are Clomid babies, and the chances of having, okay, so here's an interesting fact that some people don't know. Twins can run in families. They don't run in dad's side. It does not matter if dad was a twin. It doesn't matter if dad had 3 sets of twin siblings. Doesn't matter. Twins only run on the maternal side of the family as a genetic thing. And that is only for fraternal dizygotic twins, meaning mom has a genetic tendency to ovulate twice. So it runs on mom's side if they are fraternal, and only in some cases of fraternal, but never in identical. Identical twins don't run in families. They're always sporadic. Interesting fact. A. Hubert, question about being diagnosed with pyelectasis and what to expect at an MFM appointment. So go back and read some of my posts when I was pregnant with Pax. That'll give you a little bit of information there. I'll try to make one like succinct video when we get a little further in this journey. But if you were diagnosed early in pregnancy and you're just having a follow-up ultrasound, it'll probably just be an ultrasound most of the time. You guys are so nice. I just read through all of your comments and your messages and all the things you leave here, and just like I really appreciate you. You're all, I don't know. I feel like how can we have this space that is so positive because of you? Because you come here and you bring happy, positive things. You want to wish me well with my babies, and you want to hear about how things are going, and you check in on me and make sure that like everything's going fine. Like you guys are just really. Do you feel like you get to grow with and get to know your patients' families pretty well? Depends. Some of them, I feel like by the time we get to the end of their pregnancy, I just want to be their friend because we've hung out like every week for so long. And some of them bring their family to appointments and we get to know all of them. And then other patients are just kind of quiet. They come to the doctor to get their advice and make sure everything's taken care of and check on the health of them and their babies, and they don't feel like being chatty, and that's fine too. I think there's a place for both of those types of relationships, but there certainly are patients who have come to be very close to me, and I've learned to kind of feel like I would love for them to come back in another pregnancy. Any of my patients I would, but there's definitely certain ones that you connect with more than others. If an OB-GYN decides to specialize, much give up all general aspects of OB, or is it possible to do a little bit of both? One second here. I'm looking at something in a momento. Why is everything messed up? Okay. If an OB decides to specialize, okay, giving up, yes. So yes, and that's actually one of the reasons why I ended up not specializing. I thought I wanted to do REI, and then I very nearly changed to ONC after my third year, and I just fell in love with operating, and I loved the pathophysiology of gen onc, but I could not give up everything else. So yes, you give up a very large portion of what you learn in residency if you decide to specialize. I don't know how to use YouTube. This is bananas. Are you big about pushing birth control? I'm not big about pushing anything. I kind of feel like people should be informed and make the decisions for themselves. But I mean, the flip side of that is like sometimes we will talk about things over and over because we think they are important and we want to make sure that people understand them. And that can be in occasions misinterpreted as us pushing things when it's actually just wanting to be 100% sure that somebody understands something. And there's a very fine line between how you do that without sounding pushy. I mean, I don't know anybody who has a vested interest in someone else being on birth control, but I do feel like there are certain patients who have certain things going on where I would talk about this more than once, and I don't always feel like it's like, do you want me to give you birth control? Okay, no. Like sometimes it's important to bring that back up or delve into why, especially if the patient had major complications. So I think that I wouldn't say I'm big on pushing it, but I am very big on making sure people are completely informed. And I think, as you guys know here, that I do a lot of counseling and I try to explain things in a way that they make sense. And hopefully that comes across as education and not as being pushy. I'm not sure. Jasmine, hello. That's okay that you're late. I'm just happy you're here. Let's see. Do you have operating room aides or assistants at your hospital? Elizabeth on IG. Yes, we do. And most of them are really excellent. What was the biggest misconception you had about being a doctor before you were one? That's a really good question. I do not know the answer to that. I'm going to have to think about that. By the way, I don't know the answer to that is a really great thing for you to all learn if you are in medicine or thinking about going into medicine. It is okay to tell a patient, I don't know the answer to that. Just last week, I told a patient, I don't know if that's safe to breastfeed. Let's look it up together. And just this week, I told a patient, I don't know if we should take you off that and switch it. Let's look it up together. It's okay not to store every single detail of everything in your brain. Obviously, there are lots of things that need to be stored in your brain, but it's okay if there's something that somebody asks you and for some reason it's not stored up there, or it is stored up there, but you can't access it at that moment. Don't make it up. Just say, I don't know. Let's look it up together, or I'll look it up and get back to you. Milo's favorite snack is every snack. Milo's favorite snack is snacks. Sammy Nicole asks about infant mortality and maternal mortality. That is a very good question, and that would take up the whole video, and we should definitely do a whole video about it. I'm not going to get into it right now because it is an extensive conversation, and it's not going to do it any justice by trying to just touch on it. Oh, same question underneath. Okay, I need to write that. We're going to put that on the list of things we need to talk about. Do you think becoming a mother changed your medical practice? I never practiced medicine, not as a mom. So I was a medical student when my kids were born. I definitely think it changed me as a person. And I can't imagine that it doesn't play into how I practice medicine now. Like, Instagram's going to cut us off probably in the next couple of minutes. So does your mom live close by? She's like an hour and a half away. Oh, a nursing/doctor Q&A. Ooh. I know some of my labor and delivery nurses at the hospital watch this. So if you're watching and you want to come on and do a Q&A with me, that would be super fun. And we could plan a time to get together and do a Q&A. Stephanie says, your twins are identical from Clomid. They are not identical. My twins are fraternal. Amelia has blue eyes. Reese has brown eyes. One is tall, one is short. Instagram's giving me a 2-minute countdown. I'm going to try to answer a couple more questions, and then we're going to move everything over to YouTube. We can stay on YouTube a little bit longer. So if you want to come over to YouTube, we'll keep answering questions over there. After Instagram counts us down. 1 minute, 44 seconds. 43, 42. I can't. Okay. Is Milo getting his own Instagram? Into this. And every Instagram with Milo in the title is taken by a dog. So no. But I do have plans to have a vlog about him in the next couple of months, just a day in the life of Milo. And I'm trying to figure out exactly how to do that and how to make it fun. Hi, Pat McRN. I'm so happy you're here, and Instagram's counting us down. We only have about a minute left. I'm going to try to run through a couple more questions, and then we're all going to move to YouTube. So if you want to come to YouTube, you can hurry up and come over to YouTube. Would totally watch a live with your mom. Great. I would have to convince her to do it, but maybe she will. When your patients have religious reasons for not using birth control, what fertility charting methods do you recommend to them? We talk about all different ones. Bedsider.org is my favorite resource, and it really depends on the patient and their level of motivation and their level of understanding. Do you believe in Sheetal's method for gender selection? I have no idea what you mean that is. Why does US infant mortality? We'll do a whole thing on that. What are we lacking? Okay, good. You have so many good questions, you guys. We'll have to do this again. Okay, come to YouTube. If your question is important to you and you want to answer it, come to YouTube. And Instagram's going to cut us off now. Okay. All right, YouTube. It's all about you now. I'm going to share this on Instagram for a little while and then make everybody come over here eventually. All right. Let's see. Favorite general OB/GYN topic to counsel patients on in clinic or labor and delivery? Definitely contraception is a fun one. I love bedsider.org and all of their materials for counseling on contraception. Infertility, I don't know, all the things come up all the time. Good thing I like it, huh? Is REI only a private practice-based field, or are there REI specialists that work within hospital setting academic medicine? Oh, there's definitely REIs who work in academic medicine. I don't think you'll find many who are mainly hospital setting, because there's a handful of REI problems. If you're watching and you don't know, REI is reproductive endocrinology and infertility, which is a specialty of ObGyn. And you do your residency in ObGyn and then 3 additional years in infertility. If you guys ever see me talk about Natalie Crawford, that's her field of practice. So yes, academic, yes, community, yes, private practice, no hospital-based. Jasmine wants to know, is there anything he wasn't expecting? I don't know. We'd have to ask him that. I would say we'll do a Q&A with him, but I don't know if he would do that. He's like extremely introverted. And actually, an interesting fact about me is I am a little bit introverted too. I know it does not seem like that on the internet, but I very much require time to recharge. Like, I usually eat lunch by myself every day, and it's not because I don't like people. It's just like after talking to people all morning, I need time to kind of recover. Not because it's bad, I don't know, but yeah. So I'm kind of like middle ground, but he's very introverted. And I don't know, our deliveries have been like extremely stressful to him. But aside from that, I don't know. Can you briefly explain getting board attending with? So in ObGyn, and it's different for every field of medicine, I will explain to you how we get to board certification in my field. And I am what we call board eligible, meaning I have not taken my oral boards, but I have taken my written boards and passed those. So everybody does undergrad, everybody does medical school, everybody chooses specialty and does their residency. I did 4 years of undergrad, 4 years of medical school, and then 4 years of ObGyn residency. After my final year of residency, I took the written board exam and I passed that. We then spend the next 1 to 5 years in practice as what we call board eligible, and we collect cases over the period of a year and then apply and take our boards in the fall of you can do it as early as your first year out and as late as your 5th year out. I think most people do it in years 1, 2, with I think 2 probably being the most common. You collect your cases, you study them, you submit your case list, and then in the fall you sit in front of the board and do an oral defense of your management of patients and answer questions in a oral exam. So I practice as an attending without being board certified because I am board eligible. I've passed half of my boards. I have not sat for my other boards, and this is a typical path to board certification. So it's not like I'm not board certified because I can't be, because I failed or something like that. I'm not board certified because I'm just not at that point where I would take them yet. I could have taken them last year, but I was due to deliver packs right in the middle of board exams. So I am taking them this year. Great. Oh, there's 52 of you here. You guys are so wonderful. I love you. You are awesome. Mental health, family diagnosis, referrals, access counseling, etc. Yeah, absolutely. So postpartum depression is a underdiagnosed and undertreated illness. And there are many reasons for this. And I feel like every time I read an article in the media, it says something like, OB-GYNs aren't checking for this or whatever. And that is not true. I talk to my patients about this at every postpartum visit. My nurses call the patients the week after they leave the hospital and ask them about postpartum depression. And now we have really good ways to get patients plugged in at our hospital, but I have worked in times where we just didn't have anywhere to send them. So I can hobble along and do the best I can. And some amount of treating postpartum depression is definitely within my repertoire. But once we start getting more than just the basics, I need this patient plugged into counseling, to a psychologist, to a mental health professional of some sort who is really trained in that, and that's very difficult. So access to mental health care in this country is extremely lacking, and there's a lot of systematic reasons for that, but that plays into a lot. I don't know. We screen every single postpartum patient for postpartum depression, and actually in my hospital, which I think is amazing, our pediatrics department gives mom an Edinburgh depression scale at every pediatric visit for her baby for the first several months, and then lets me know if mom is ranking high on that and she feels like the pediatrician feels like mom may need additional follow-up. So I really appreciate how well our pediatricians here have integrated this into their practice as well. Kendall Chief, what's the difference between DO and MD? I actually have a blog about this that I think was written like 10 years ago or so. Animal, the DO is trained in osteopathic manipulative medicine, but as far as medical training, we're all trained the same. We all do residency together. A DO is absolutely as capable of taking care of you as an MD. I don't know why there's like this bias against DO, or it's just less well known, I guess. Do you recommend birth control for endometriosis control? Birth control is one option for potentially treating endometriosis. It's not the only option, and it's not the best option for everybody, but it's certainly an option. I'm going to wrap this up soon because it's getting late, and I slept at the hospital last night and I am tired. And I did not take a nap today, and I should have. Aaron G, did you have any complications with any of your deliveries? Pregnancy until like 34 weeks. And then I swelled up so big, I have never seen anything like it. Even still well, I've had a couple of patients with worse swelling, but it was really significant. In fact, I very much wish I had a picture of it, but I do not, because I was horrendously embarrassed. And then I got preeclampsia, and they were delivered at 35 weeks by C-section because they were also both, well, Amelia, baby A was breech. So I had severe preeclampsia. I was in the hospital for a week trying to get my blood pressures under control, I think, and I went home on blood pressure medicine. With Milo, his birth story is on my blog. I have not done a video on it, but I was induced and I was a VBAC induction, and my blood pressures were high again. And hey, if you're still, anyway, I was induced for blood pressure issues at 37 weeks, and then I abrupted during my induction, and that was a little bit traumatic thing. He did fine, obviously, but his birth was extremely scary to me, and his birth story is on the blog. And then with PAX, I don't think I really had any complications. My blood pressure didn't even ever get high. It was miraculous and wonderful. I'm going to attribute it to not being in medical training anymore when I was pregnant with him. I also gained less weight with PAX than I did with Milo. OB inclined medical student came over here from the IG stream. Thank you, Sydney. Welcome. I am very glad you're here. Was wondering if or how you encourage breastfeeding for your patients, what conversations you have prenatally and around the time of delivery. I usually ask prenatally if they plan on for conversation. I encourage them to make frequent use of our lactation consultants when they deliver. And I also highly recommend taking a breastfeeding class if breastfeeding is important to them, because that's something I find to be very helpful to women who are wanting to breastfeed. Aside from that, we will answer many specific questions if patients have them, but obviously I can't focus solely on breastfeeding in the prenatal period. So it's mostly, we'll talk about it as much as a patient wants, but if they don't have specific questions, it's not one of my main things that I counsel on. But I usually always ask if they plan on breastfeeding if they have questions about it, and encourage them to use our lactation consultants in the hospital, who are absolutely wonderful. Whitney Landrum, just found out I'm pregnant, not getting my first ultrasound until mid-March. How do I know everything is progressing smoothly until then? I don't know how many about first ultrasounds, because I can't really talk about like you specifically, but we usually do the first ultrasound somewhere around 6 to 10 weeks. The timing in there is really not important unless there's something else going on. If you've had losses before, things like that will play into it. But it is often very hard to get in earlier than 10 weeks, and that's okay, because there's nothing we would do different based on anything at that point. And there's no way to know for sure everything's going fine, but generally in the absence of symptoms that are concerning, things are going fine. And you want to give the pregnancy long enough to have baby growing enough where we can see it and measure things and get a heartbeat before you have your first ultrasound. Otherwise, we'll cause more problems than we solve by scanning too early and not being able to see anything. And that's always extremely anxiety producing for patients. So that's the Edinburgh postnatal depression scale. Whenever they came in, we'd refer if needed. The clinic had no real follow-up plan in place. April, thank you for that. I don't think the clinic has a real follow-up plan. I follow up with my patients as needed for that. So if someone has severe depression, if I'm getting them plugged into counseling, I will have them let me know that they got in. If I'm starting someone on medications, then I'll have them come back. And I always see these patients back. I feel like you just make follow-up as the patient needs it. So I that's probably practice styles vary on that. Alexis Marie, hey, Dr. Jones, can't believe I forgot you're going live. Hi, that's okay. It will be all up on YouTube if you would like to rewatch it. Tips, Ellen, going to the doctor. I still don't love going to the doctor. Who likes to go to the doctor? That would be weird, right? I don't know. Just finding somebody that you trust and knowing that we're there to help you. And I don't know. I don't like going to the doctor either. And then my ObGyn is my partner in my office, and it still was, I think, like pulling teeth for her to get me to schedule appointments. And then I no-showed my postpartum appointment. I was wondering, I need to delete that out of this video. That's a bad example. Any tips for staying motivated in undergrad? Classes we know will have no meaning later in our career. This is something you're going to encounter very frequently throughout undergrad and medical school, actually. And my tip is, don't ever look at a class as having no meaning, or go through classes or not go through classes because of what you will have as a career. You're putting down stepping stones. So you have to have those classes in order to eventually learn the things that you do need to know for your career. And so they do have meaning on that. You may not use them directly, but you will use them because you need them to learn other things. I think finding joy in learning is the only way you ever get through pre-med and medical school and residency and being a lifelong learner in general. Like, you just have to be passionate about learning. So the same could be said if you know what you want to go into as a medical student. You know, like, I want to go into general surgery. I'm never going to use ObGyn. I hate this rotation. How do I get through this? That's a terrible. You're still going to be peripherally needing to know things about OB/GYN and women's health and pregnancy. So I think just finding a general passion. The best medical students I worked with, one of them I follow on Instagram, and I talked about him in the live stream last time. His name is Joey. He was so wonderful. Like, he stands out in my brain as this person that everybody should emulate. Like, he was always passionate about learning. He had no interest in being an OB/GYN, but every day he showed up and he wanted to learn something. That's the only way you make it not miserable. What do you know about amniotic embolism? I know a lot about that. Why do you ask? What do you want to know about amniotic fluid embolism? That's a very vague question. It's basically amniotic fluid, which is extravasated into the bloodstream and then ends up in the pulmonary vascular, causes usually hypoperfusion and eventually DIC and a whole cascade of other massively terrible complications, but it's a very bad complication to have. That's what I know about it. I mean, and a lot of other things that would answer textbook questions, but yeah, it's bad. Survival rate is very low, but improving. There's not a lot of literature on amniotic fluid embolism because it's so incredibly rare and hard to study. There is some literature emerging about various ways to treat it. It's hard to prevent, and mortality rates are exceedingly high as compared to other complications of pregnancy and other complications of almost every disease process that we know of. All right, guys, that's all the questions on here. Thank you for coming. Thank you for being full. If you have other things you want to talk about, I think instead of just doing Q&A, at some point we will have like a schedule of topics, and that would be really beneficial. So we'll come up with some of those in the coming weeks and months. And yeah, so great. Thank you for being here. You guys are awesome. Seriously. Your support on this platform and on Instagram is the only reason that I have this platform. And I feel like we are doing great work together, spreading good information, advocating for science, and I only get to do that because of you guys. I'm serious. Thank you. So, all right. See you next time.